tumors.
Thank you. I'm NORIYUKI TOMIYAMA from Japan. Today, at first, I'll show you the classification of mediastinal compartment. And next, I'll talk about imaging of thymic tumors and TNL staging. And finally, I'll introduce some clinical questions. This slide shows Ferguson classification of the mediastinum on the lateral chest radiograph. As you know, Ferguson defined two lines to separate mediastinal space. The first line is an imaginary line which sits in front of trachea, but behind the heart line, separates the anterior and middle mediastinum. The second line, 1 cm back from the anterior edge of the vertebral bodies, separates the middle from the posterior mediastinum. This classification is very useful, but as you know, this classification has some limitations compared to the classification defined by CT. This slide shows the modern definition of mediastinal compartment defined by Thymic. This manuscript was published in JTO in 2014, and I'm a co-author of this manuscript. Here, let me show you about Thymic. Thymic is the International Thymic Malignancy Interest Group. This is the homepage of Thymic. Please visit this homepage if you are interested in. Thymic modern definition has a 3-compartment model, including prevascular, visceral, and paravertebral. Boundaries of each compartment is clearly defined by CT. Okay. Prevascular compartment is shown in purple color. Prevascular compartment of a prevascular compartment is clearly defined by CT, and the boundaries, a prevascular boundary are stratic inlet superiorly, diaphragm inferiorly, sternum anteriorly, lateral pleural reflection laterally, and anterior to the pericardium posteriorly. A visceral compartment is shown in blue color. Please pay attention to the posterior boundary. That is a vertical line connecting a point on each thoracic vertebral body at 1 cm posterior to its anterior margin. This line is the same as the line defined by Ferguson on the lateral chest graph. Okay. Paravertebral compartment is shown in yellow color. As you know, there is no potential space for paravertebral compartment. This slide shows the approach to the prevascular compartment. The common neoplasms seen in the prevascular compartment are thymic epithelial neoplasms, including thymoma, thymic carcinoma, and thymic neuroendocrine tumors, thymic lymphoma, mature teratoma, germ cell malignancies, and metastatic diseases. Non-neoplastic lesions are seen here, thyroid goiter, thymic hyperplasia, cystic lesions such as thymic and pericardial cyst, and prevascular lymphatic abnormalities. Today, I'll talk about these lesions. Okay, let's move on thymoma. As you know, thymoma is divided into non-invasive thymoma and invasive thymoma. Non-invasive thymoma are usually seen as a round or oval shape with smooth contour and also homogeneous enhancement. Whereas invasive thymoma are more likely to have plug shape, lobular or irregular contour, and inhomogeneous enhancement. A cystic portion or calcification are sometimes seen. Historically, thymoma is divided into lobules by grossly visible fibrous band that extend into the tumor capsule, tumor substance from the capsule, like this. Sadohara et al. Reported about the comparison of CT and MR imaging of thymic epithelial tumors in the detectability of each findings of capsule, septum, calcification, hemorrhage, and necrotic or cystic component, lymphadenopathy, pleural effusion, and great vessel invasion. As you can see from this table, CT is superior to MR in the depiction. MR is superior to CT in the depiction of capsule, septum, and hemorrhage. Okay. This is a case of type A thymoma of 51-year-old woman. A T1 weighted image shows a round mass in the anteromediastinum with smooth contour. And we can see low intensity limb here on T2 weighted image, which corresponds to capsule. Histologically, the tumor is surrounded by a fibrous capsule, and also microscopic capsular invasion is evident here. So this tumor is T1A. But we cannot see this kind of microscopic invasion on CT or even on MRI. This is a case of type B1 thymoma of 53-year-old man. A T1 weighted image shows a lobulated mass in the anterior mediastinum. And we can see low signal band here on T2 weighted image, which corresponds to fibrous band. Histologically, lobulated configuration separated by fibrous septal is seen. Pericardial invasion is evident. So this is a T2. Okay, let's move on thymic carcinoma. Thymic carcinoma is quite different from thymoma histologically and much more aggressive clinically. Thymic carcinoma usually manifested as a large anteromediastinal mass with irregular contour. Necrotic or cystic portion or calcification are sometimes seen. The most important CT findings is mediastinal or hilar lymphadenopathy. Pleural effusion can be seen. Okay. This slide shows CT findings to differentiate thymoma and thymic carcinoma. Suggested features of thymoma is smooth contour and round shape. This is usually seen in non-invasive thymoma. Suggested features of thymic carcinoma are irregular contour, mediastinal or hilar lymphadenopathy, great vessel invasion, and distant metastasis. Okay, let's move on to thymic cyst. This is a case of simple thymic cyst. As you know, simple cyst usually seen as a water density mass with imperceptible wall on CT and T1 weighted image on low intensity on T1 weighted image and high intensity on T2 weighted image. Dr. Akuma et al. Reported about high rate of unnecessary thymectomy and its cause. They concluded the high rate of unnecessary thymectomy was due to misinterpretation of thymic cyst, thymic hyperplasia, and lymphoma as thymoma on chest CT. Why do we misdiagnose a thymic cyst as thymoma? As you can know, yes, thymic cyst can show increased CT attenuation if hemorrhage or infection occur. Non-conventional CT show soft tissue density mass in the anteromediastinum. The average CT value of this mass is 50 Hounsfield unit. So you may misdiagnose this mass as solid tumor. But control CT shows no enhancement in this mass. So here we have to suspect this mass may be cyst. In this situation, MRI is very useful. This mouse showed high intensity on T1 weighted image and high intensity on T2 weighted image. Gadolinium enhanced T1 weighted image show no enhancement. By using water sequence, we can diagnose this mass as cyst with confidence. Okay, let's move on to thymic hyperplasia. As for thymic hyperplasia, chemical cyst imaging is very useful. Takahashi et al. Reported about characterization of the normal and hyperplastic thymus on chemical cyst MR imaging. Normal and hyperplastic thymus usually show homogeneous decrease on opposed phase compared to that on in phase. They calculated chemical cyst ratio, which was calculated by the intensity on opposed phase divided that on in phase. The chemical shift ratio in this case is 0.55. Then how about thymic tumors? Okay. This is a report from Inaoka about the differentiation with chemical shift MR imaging of thymic hyperplasia and thymic tumors. Chemical shift ratio in hyperplasia group was significantly lower than that in tumor group. Chemical shift ratio in tumor group is almost 1.0. That means usually thymic tumors don't show any decrease in intensity on opposed phase. Okay? Then we can differentiate between the two. Okay, let's move on to thymic lymphoma. Tateshi et al. Reported about characteristic CT features to differentiate each subtype of thymic lymphoma. As you know, there are three representative subtypes of thymic lymphoma. They are primary mediastinal large B-cell lymphoma, precursor T lymphoblastic lymphoma, and Hodgkin lymphoma. Primary mediastinal large B-cell lymphoma usually have regular control, vascular involvement, and absence of cervical and abdominal lymphadenopathy. Precursor T lymphoblastic lymphoma usually has cervical or inguinal lymph nodes, pericardial effusion, and absence of surface lobulation, no surface lobulation. I think you are familiar with Hodgkin lymphoma. Yeah, Hodgkin lymphoma usually have surface lobulation, mediastinal lymphadenopathy, and absence of vascular involvement. Yeah. Even if a tumor surrounded the vascular vessels, yeah, there is no vascular involvement. Okay, let's move on to thymic carcinoid. Yeah. What we should keep in mind is multiple endocrine neoplasia type 1, MEN1 associated thymic carcinoid. MEN1 is seen in 20% of patients with thymic carcinoids. The symptom of thymic carcinoid is Cushing syndrome, not carcinoid syndrome. The CT and MR patterns are not specific, so they are indistinguishable from other thymic tumors. So this is a CT and MR images of thymic carcinoid. Yeah. They are similar to the images of invasive thymoma or thymic carcinoma. So we cannot differentiate these ones. But now we know we can diagnose if the patient has MEN1 associated thymic carcinoid. This patient is a medical doctor in his 30s. Yeah. Abnormalities on the screen chest graph was noted. Yeah, we can see irregular widening of the upper mediastinum. Yeah. And we can see the irregular margin mass in the antemediastinum. We can see a tiny calcification in the tumor. The patient was referred to our hospital for surgery, and the diagnosis at the previous hospital was invasive thymoma or thymic. At first, I saw this CT image. I agreed with the diagnosis, but I found two other CT findings. This is parasite tumor, and the other one is pancreatic tumor. So now we have to consider MEN1 associated thymic. Okay? Oh, sorry. This is done. What next? We have to investigate. Of course, that is pituitary gland. Yeah, we can see pituitary tumor on brain MRI. A CT-guided needle biopsy of the thoracic mass was performed, and thoracic carcinoid was performed. This is a TMN staging system. Stage 1, Stage 2A, Stage 3A, Stage 3B has no lymph node involvement or no metastasis. And Stage 1, 2, 3A, 4B correspond to T1, T2, T3, T4 respectively. Stage 4A has N1 or M1A. Stage 4B has N2 or M1B. This is Stage 1, T1, N0, M0. That is T1 if the tumor has no direct invasion to peripheral pleura. If yes, that is T1B. This is Stage 2, T2, M0, M0. The tumor had a direct invasion to the pericardium. Okay? Stage 3A, T3, N0, M0. Yeah. Stage 3 means the tumor had a direct invasion to the followings: lung, phrenic nerve, bronchocephalic vein, superior vena cava, extrapericardial pulmonary artery and vein, and chest wall. That is Stage 3B, T4, N0, M0. Stage 4 means the tumor has a direct invasion to the followings: archivessels, myocardium, interpericardial pulmonary artery, trachea, and esophagus. Okay. Stage 4A, that is the patient has N1 or M1A. N1 means deep thoracic nodal involvement, and M1A means pleural or pericardial nodules. We can see non-contact CT shows irregular large mass in the anterior mediastinum with classification. And please note two pleural nodules. Okay? Pleural nodules usually have the possibility to be dissected because tumor volume dissection, which could contribute to patient better survival. This is if we see a pleural dissemination with lung cancer, we never do. Of course, we never do operation. Yeah, but this is a big difference between the two. Okay? Stage 4B. This means N2 or M1B. N2 means deep intrathoracic lymphadenopathy or cervical lymph nodes. M1B means distant metastases, including pulmonary nodules. Okay, well, let's move on to clinical questions. Question 1: is MR recommended for the detection or differential diagnosis of thymic epithelial tumors? Here, let me show you the data of our study about percentage of correct diagnosis of anterior metastatic tumors by CT and MRI of 95 patients, including thymic cyst, thymoma, thymic carcinoma, thymic carcinoid, mature teratoma, malignant germ cell tumor, and malignant lymphoma. A CT is equal was superior to MRI in the diagnosis of these diseases, except for thymic cyst. Okay. Diagnostic accuracy of thymoma by CT or MR are equal. And diagnostic accuracy of thymic carcinoma by CT is superior to MRI. Okay? So, for answer, for the detection, CT is recommended, not MRI, because CT has a better spatial resolution than MRI. Okay? And the MRI is suggested in the differential diagnosis of thymic cystic lesion or thymic hyperplasia and in patients who have iodine allergy. Okay? Question 2. What is the imaging modality for TMN staging for the patient who have a suspicious thymic axial tumor? Okay. Of course, that is enhanced chest CT, including upper abdomen. MRI is recommended in some situations, which I mentioned in the previous slides. FDG PET CT has the potential to find out an unexpected metastasis, but there are no enough evidence to serve as TMN staging. This is the last question. How do you treat an incidentally found small antimetastatic lesion? Do you recommend operation for this kind of lesion? Here, let me show you a nice paper written by Sun-Ho Yoon about an incidental antimetastatic nodular lesions on chest CT in asymptomatic subject. They reported the prevalence of incidental nodular lesion was 0.73%. Most lesions had CT features that were indistinguishable from thymic axial tumors, but a considerable portion of the lesions were suspected to be benign. Incidental thymic axial tumors were more prevalent than clinically detected tumors or early-stage cancer and showed favorable outcomes. Okay, then answer 3. This is in Japan, okay? Operation is recommended when we suspect the small anterior metastatic lesion, maybe a solid tumor. So a surgeon wants to do operation, okay? Operation is not recommended when we suspect that a small anterior metastatic lesion may be a cyst, including thymic cyst or apical cyst, okay? Okay, to sum up, today I talked about these 3 points. Thank you very much for attention. Thank you.
Thank you, Doctor, for the nice presentation and covering up all thymic tumors. Unfortunately, we don't have enough time for questions now, and we'll move on to Dr. Nihal Battuti, Associate Professor of Diagnostic Radiology.